So today what I'm really going to sort of cover is an overview of the features, the mechanisms, the evaluation and the treatment of painful chemotherapy-induced peripheral neuropathies. Now I'm going to abandon that straight away and call it CIPN because it's a lot easier for me to say. So CIPN is a set of primarily sensory but also motor and autonomic symptoms due to peripheral nerve fibre damage and altered function caused by neurotoxic chemotherapeutic agents. And peripheral neuropathic pain is pain caused by a lesion or disease, or in the case of this presentation, chemotherapy, to the peripheral somatosensory system. So that gives you a sort of basic sort of understanding of what we're going to talk about. So most neurotoxic drugs cause structural damage and not just functional damage to axons. And both large myelinated fibres and small myelinated fibres are affected. However, unlike the large fibre neurons, the small fibre neurons have a worse or a poor capacity for repair. And this is due to the relative lack of myelin. And here there's less interaction between the axon and its Schwann cells that between them are thought to promote remyelination and the restoration of axonal function. So the repair of neuron with thinner myelin is often a lot slower, and this is why these sensory symptoms persist for a lot longer and sometimes are irreversible depending on the dosing. The dorsal root ganglion is the area that's most damaged, and this is because it's not protected by the blood-brain barrier, and this makes the DNA in the cell body a lot more susceptible to sort of neurotoxic effects. The autonomic nerves are a little bit less sensitive. The symptoms are quite rare, but these neurons are, on the whole, thinly myelinated or unmyelinated fibres. So it's not really clear why these are less susceptible, but after doing a little bit of reading, I can only come up with it may be that the presynaptic, sympathetic and parasympathetic cell bodies lie within the central nervous system and are therefore more protected by the blood-brain barrier. If anyone can come up with anything better, I'll be pleased to hear from them. So contributing factors. Chemotherapy agents are neurotoxic both as high single doses and high cumulative doses, especially concerning the platinum-based drugs. There are other drugs involved, such as the taxanes, vinca alkaloids and bortezomib. Concerning the other factors, and this has been touched on quite a lot today, are peripheral neuropathies from pre-existing conditions, alcoholism, diabetes and post-hepatic neuralgia. There is a study that shows that people with a 5-year history of diabetes prior to the onset of cancer show a significant risk of getting this chemotherapy-induced peripheral neuropathies. Other factors, tumour infiltration to the spinal nerves, surgical trauma, and interestingly, genetic susceptibility. And this is an enzyme called the GSTP1. I've got no idea what it stands for. And this is significantly associated with severe CIPN. And this is because this enzyme is expressed in the dorsal root ganglion and it protects against oxidative stress and is highly expressed during chemotherapy. And it plays a significant role, especially in the detoxification of platinum drugs. So people with this type of polymorphism are a lot more susceptible to the neurotoxicity, but more importantly, they're less likely or they're more likely to discontinue treatment. So the features, what does it look like? Sensory symptoms are due primarily to increased neuronal excitability, so the paresthesias, the tingling, the itching, but also the dysthesias, the discomfort, the pain. So this is more the cold pain, the burning pain, the lanciating type pains. And just going back to this sort of issue that we've had all along about experimental studies versus human studies and why is some of this data good with experimental studies with animals and not with humans. And this is this whole central sensitization issue that Michael was talking about this morning. So there's a lot of pain sensitivity that comes along with CIPN. So pain, an increased pain response to a mildly noxious stimulus, which is referred to as hyperalgesia, and a painful response to non-noxious stimuli, which is referred to as allodynia. And these are present in up to about 80% of people presenting with painful neuropathies. So on the one hand, you've got the neurotoxic damage, but on top of that, we could have, and that I don't know, this central sensitization that is a more functional aspect rather than a structural injury due to the chemotherapeutic drugs. We also have decreases in neuronal function, so numbness, decreased sensation, decreased position and vibratory sense, and decreased reflexes. And although motor symptoms are relatively rare, weakness and the difficulty with the fine motor skills are the most common. However, the difficulty with the fine motor skills might be due to numbness, that they can't feel what they're trying to manipulate. So again, you have to try and differentiate between the two. Concerning autonomic symptoms, in the digestive tract we can think about constipation as a possible sign, early satiety, bloating, urinary retention, loss of libido, alterations in blood pressure and heart rate. So these are things to consider when you're coming to do your assessment of people coming in with this particular problem. So now if we take a look at some of the mechanisms involved, and I'm going to sort of keep it as brief as possible. So given how chemotherapeutic agents affect cancer cells, it's not surprising that many of the symptoms associated with CIPN are due by and large to the anti-cancer mechanisms relating to cellular apoptotic pathways, where they're firstly responsible for, if I can find, is there a... Sorry, I'll just keep going without the pointer. So mitochondrial damage as a result of oxidative stress, alterations in axonal transport, which is related to myelin and microtubule degeneration. Okay, cool. Neuronal excitability, and this is because of increased excitability or increased expression of ion channels, chiefly that of sodium, calcium, and the TRP channels, which I'm going to talk about more in a moment. Neuroinflammation, again, glial cells and astrocytes are affected by chemotherapy as well, and they will release inflammatory neurotransmitters, which also add to the boiling pot, if you like. And of course, damage to the dorsal root ganglion and the cell bodies. So if we take this a stage further, or to expand on the previous slide, I've put this thing together just to really show you what happens in the postsynaptic area within the spinal cord. So first of all, as I said before, there's increased activity in sodium channels, and this is shown to be responsible for mechanical hyperalgesia. So in experimental animal studies, this is reduced with sodium channel inhibitors, so something like lamotrigine, for example. B, calcium channel expression increase. Again, this is responsible for mechanical allodynic responses, and this has been shown again in animal studies to be reduced by gabapentin. NMDA receptors. Now, this is quite an interesting area that's relatively new, and it's not so much related to what happens or the increased activation of the NMDA receptor itself, but the chemotherapeutic agents increase the extracellular glutamate that actually activates the NMDA receptors. Okay? And it's shown, again in animal studies, that this is the main cause of CIPN-related allodynia, this constant bombardment of the NMDA receptors. As I said before, the glial cells are activated, and this helps to release inflammatory neurotransmitters such as TNF-alpha and various interleukins. And something I'm going to talk about more in a minute are the activation of TRP channels. So this is what happens on outside the cell, and this determines what happens inside the cell. So intracellularly, this whole sort of shaboodle of all of these different sort of mechanisms of action activate intracellular calcium stores, and this is the real sort of hub of where things tend to go wrong. So this is responsible directly and indirectly for mitochondrial damage, oxidative stress. This in turn leads to demyelination and disruption of the cytoskeleton, and it also eventually leads to inhibition of DNA replication and eventual cell death. So even though this is a sort of brief overview, you can sort of get the picture of what happens both outside the cell, the neuron, and inside the neuron. Let's go through that. And this sort of reinforces the fact that I was really given an overview. So this is So there are quite a few different lots of different areas of mechanisms. So what this Venn diagram really shows you are the three different areas of mechanism dysfunction. So the blue circles represent what happens at the periphery, at the nerve ending. The grey, and there's a multitude, is what happens, or the mechanism dysfunction at the dorsal root ganglion, and the yellow are what happens in the spinal cord. So you can see there's too much to think about, and again, one drug fits all, or one type of treatment fits all, is never going to happen in this type of environment. And this is why animal studies are really good, because you can isolate certain types of stimuli and isolate certain types of channel, but you can't look at everything. And I think this is where the problem lies. And then going into human studies and adding all of the cognitive and fear and emotion, fear avoidance and all of that type of stuff on top of that, adds a whole different dimension to what you're trying to achieve when you're trying to go from animal to human studies, especially the clinical trials with the RCTs. So this is the last one for the mechanisms, I promise. And I want to take a closer look at the thermal and mechanical hyperalgesia. So the first graph, this shows withdrawal thresholds for tail immersion at 10 degrees of water. Now this is considered noxious, and anyone who hasn't stuck their hand in 10 degrees of water, or anyone who has will know this is pretty cold and it hurts like hell. When you look at 10 degrees, it doesn't actually look that cold, but when we've set up our studies, when we've tried it ourselves, we're actually quite surprised how cold it is and how much we want to take our hands out. But what you can see here is the dosage of, in this case, oxaliplatin. The filled circles are the vehicle, and on the way down is 1, 3 and 6 milligrams per kilogram of oxaliplatin. And what you can plainly see is that the more increased the dosage, the less time it takes for the tail to be withdrawn. Okay? And the same applies to the second graph, which is related to a non-noxious water temperature, which is 21 degrees. So again, if I can get my mouse back on track, the higher the dose, the less the time the tail stays on the pad and it's withdrawn. So these two graphs relate to investigations into TRP channels, so the TRP M8, which is synonymous with cold stimuli. The next set of graphs is more related to TRP A1, which is related to mechanical stimuli. So what we have here is the number of pore lifts out of 5 to 3 different types of mechanical stimuli. So you've got non-noxious, intermediate, and noxious. And again, the higher the grade, the more pore lifts out of 5 occur. So if you look at the first graph with the non-noxious, the control and the 1 milligram per kilogram are not too bad. They stay virtually below the 2 pore lift threshold, but you can see the 3 and 6 milligrams per kilogram well above that threshold for 2 pore lifts out of 5. So interestingly, the same guys who did this study then looked at the TRP M8 and TRP A1 null mice, and there was absolutely no suspensive behaviour for any of the same protocols. So again, there's promise, but how do we translate that promise? So to move on to differences between acute and cumulative CIPN. Acute tends to be episodic. It starts during the infusion and lasts for days after. Its frequency is about 80-90% within people who are taking it, and the clinical findings, dysthesias, parathesias in the distal extremities, but also periorally, and in the case of oxaliplatin, cold-provoked symptoms, because the chief ion channel that's provoked is the TRP M8. Now, if we look at cumulative, it's more persistent, and the more cycles of chemotherapy you get, the more persistent it comes, and the less likely it is to go away between chemotherapy cycles. There's also a coasting effect, and this refers to the progression of symptoms several weeks or months after the chemotherapy cycles have stopped. And for this, the most recent research shows about between 750 and 800 milligrams per metre squared as a cumulative dose. And that's what we're working on for our study. We're looking at ways of predicting who is most susceptible to painful chemotherapy-induced peripheral neuropathies. And there's no improvement between cycles. And here's a nice little graph, just to sort of show you the timeline of how acute starts and how it disappears between cycles, and that phase into the more cumulative, persistent, painful chemotherapy-induced peripheral neuropathies. So it's a challenge to evaluate. It's not only a challenge to evaluate or to treat, but it's also a challenge to evaluate. There are many, many different grading scales. And unfortunately, CIPN is not considered, it's considered a minor problem in relation to all the other side effects that go on with chemotherapy. And it's usually considered that these will resolve on its own over time. The other reason that diagnosis is not very easy, or evaluation is not very easy, is because there's quite a few different types of grading tool that people can use. So the data is not uniform. And we'll take a look at a few of these in a moment. And they also mostly rely on self-reporting of symptoms. It's very difficult to objectively measure or assess. And patients find it very difficult to describe unpleasant sensations unless they are obviously painful. So people might say they have extreme cold or extreme burning symptoms, but they might not relate it to being painful. And the other thing about people on chemotherapy is that they don't want to admit that they have these symptoms because they don't want to have a reduced dose or discontinue the chemotherapy for fear of what might happen if they don't do that. So to assess, we first of all have the subjective, the pain, the paresthesias, and the autonomic signs. So ask about them, constipation being one of them, early satiety, dizziness, arrhythmias due to altered heart rate, blood pressure. Physical examination, if you've got the equipment, large and small fibre sensory testing, gait and balance, something like Romberg's works really well with this. Muscle strength and reflexes all can be done very quickly and very easily. Fine motor skills, and don't forget, objectively to assess bowel sounds, blood pressure and pulse. So here are 3 grading scales, and we're going to be using 2 of them. The top one is the common terminology criteria for adverse effects, and this is used here at Royal North Shore. And this refers to the increasing effects through the grades on symptoms that affect activities of daily living. So if you look at this grade 2, for example, this refers to instrumental activities of daily living, which is like washing up, doing the dishes, making a bed, all that type of stuff. Whereas grade 3 tends to, when it gets really bad, people aren't able to care for themselves. So this is quite useful for that type of stuff. We want to use the next one, which is the Oxler-Platten grading scale. And this really is useful for us as a research tool because it relates more to the time scale of the regression of symptoms after you've had the chemotherapy. So if you look at grade 1, the paresthesias or the altered sensation is completely gone within 1 week of the first chemotherapy cycle. Grade 2, 14 days, and grade 3, there is incomplete regression of symptoms between cycles. So for us, that's a really good tool to use. The Eastern Clinical Oncology Group have also got one, and this refers similarly to the top one, which refers to the progression of impaired function, if you like. So only a couple of slides left. This is taken from a review of mechanism-based treatments for painful CIPN. And if I just highlight the end column, you can see that there's no real benefit to any of these apart from a couple. So the first 2, the nortriptyline and amitriptyline, TCAs, gabapentin, calcium channel blocker, lamotrigine, a sodium channel blocker, no benefit compared to placebo. Whereas when we come to the duloxetine, this has surprisingly shown a reasonable reduction in painful CIPN. So what is it about duloxetine, with, let's say, something like nortriptyline and amitriptyline? Because those TCAs have serotonin, norepinephrine type activities similar to the SNRIs. So what is it about that duloxetine that makes it a little bit different? And it may be due to different affinities for noradrenergic transporters compared to TCAs. We don't really know. And just at the bottom here, we have 2 topical transdermal. One is a baclofen amitriptyline ketamine mix, and again, promising signs, whereas the ketamine amitriptyline mix, again, no benefit compared to placebo. So what is it about the first one, is it the baclofen, or is it the combination of all three that has the effect? I'm not going to spend too long on this because there's been a lot of small studies relating to things that help protect against these symptoms. Antioxidants, omega-3 fatty acids, amino acids, and magnesium and calcium infusions. All the small studies suggest some benefit. All the largest clinical trials don't show any benefit. So we have to really come back and figure out what we're doing, look at the rigour of the actual trials that we're trying to do, and try to single out or try to combine different types of resource to see how we can improve these neuroprotective agents. So take-home points. Painful peripheral neuropathies with chemotherapy affect about 80% of the patients and is dose-limiting. So we have to identify individuals at risk for severe neuropathy, and we can do this by assessing pre-existing conditions associated with painful CIPN, baseline assessment of peripheral neuropathies prior to the initiation of cancer therapies. So you sort of get a sensory profile or a patient stratification where you can tailor both chemotherapeutic and analgesic treatment. Ongoing assessment for CIPN is recommended as a chemotherapy progresses. So here, regular testing as performed at baseline through the chemotherapy therapeutic cycles will help determine the onset and the dose of painful CIPN, and in the future predict the onset dose and determined by what baseline evaluation. And finally, consistent documentation that provides not only reliable but uniform data, as well as informed and ongoing communication between the caregiver, the healthcare providers, and most importantly, the patients. Thank you very much.
Thanks very much, Phil. I don't know about your practice here, but I'd say up in Brisbane where I work, 100% of people would be with this would be on Lyrica, and very few would be on duloxetine. Is that the same as here? Why is that happening? Melanie? Same with you? Questions for Phil? I must say I didn't realise that it was often so transient, because a lot of patients, well, maybe we just get to see those ones, but it's often the dose-limiting factor of the chemotherapy, and a lot of it seem to get it forever, and it doesn't go away.
Yeah. Mm. That's what we're hopefully going to try to predict with this study.
Yeah, that'd be great.
Thank you.
Well, here we go.
Oh.
We very occasionally get a request for topical capsaicin. Is there any evidence for use of that?
I'm not going to say, not that I'm aware of it, this is because I haven't looked, would be the honest answer to that. But I could definitely get back to you on that.
I think there's certainly evidence of capsaicin, isn't it, for neuropathic pain, but I don't know whether there is any specifically for peripheral neuropathy like this. Do you know, Melanie? Mm.
Something worth considering.
Is duloxetine just a better SNRI inhibitor than a triple and the others? Because they're pretty drugs.
Well, I think in this case it must be. There must be something about the noradrenergic effect of that part of the compound compared to the TCAs.
But then again, there's better evidence for the good old-fashioned TCAs in some neuropathic pain than the newer agents. So maybe it's the dirtiness that helps.
This resembles more a diabetic neuropathy in terms of pathophysiology, doesn't it?
Yes.
And that's what duloxetine is beneficial. And amitriptyline isn't. So I think pathophysiologically,
I think you're probably right with it.
Don't you think the dirty drugs, though, are often good because it's covering lots of different... And I think it's very interesting what Philip says, like in mice, maybe it doesn't work, but humans have got all the extra depression, anxiety, mood swings, everything that's probably so important, isn't it? All this, yes.
I've had some collaboration with a research group here in Sydney who's looking in detail at chemotherapy neuropathy, and their view is that pain isn't actually a problem, and I think it comes back to this whole definition of what pain is. specialist, but they say that, patients don't complain of pain. What they complain of is numbness and tingling and imbalance and loss of mental dexterity, and very few people complain of what these primarily oncologists consider pain, and so I think that's an intriguing part of it. And as I recall, that one study of duloxetine, it was the only study where pain and cancer was being like inclusion criteria, that pain score had to be greater than 4 out of 10. All the others are just for neuropathic symptoms. So it's this kind of definitional kind of issue within pain about what unpleasant sensory and emotional experiences of pain and what aren't. I guess.
I mean, looking through the literature, it's virtually underreported in every single article. As I say, the one you just talked about is one of the very few that actually has a pain score in it.
Yeah. And in your experience working at the Director of Cancer Services, painful chemotherapy neuropathy is a big problem?
Yeah. Well, no, but it's really why you say that. I'm just trying to think what people complain of. They complain of, don't they, that it's like walking on cotton wool or something, and they complain that it's really uncomfortable to put their shoes on, and they complain that they're unsteady. So, you might be absolutely right. We just sort of lump it all together in a pain box, but maybe we should be differentiating it more.
Or maybe the key is the central sensitisation that lies on top of the actual structural damage. That may be something to look at.
I think it was Gav who put Turlo who put up that thing, that ISP definition as unpleasant sensory and emotional experience associated with actual or potential tissue damage. So I would have thought it's pain, but
I think in a lot of cases just lump it under dysesthesia instead of separating into lots of different types of symptoms.
And I think a lot of cancer patients too think that they're getting a treatment, so this is something that comes with the package, and they should just put up with it because theoretically their cancer's going to go away.